So, shall we start, madam?
Yeah. Hello everyone. A very warm welcome to all the participants joining us today. This is Ada from IGCP and it is pleasure to have you all with us for this insightful continuing medical education session. We are diving into a clinical challenge that often keeps physicians on their toes. So topic is hyponatremia made simple endocrine causes every doctor should know. Introducing our guest speaker to help us navigate this complex topic, and we are honored to have a distinguished expert in this field. So, I am introducing Dr. Abuday Verma. He did MBBS, MD in medicine, DNB, and FAC. He is the position in associate professor at the Department of Endocrinology, Index Medical College in Indore. So, with this, sir, I can hand over this session to sir. Thank you.
Thank you, Ms. Sada. So, good evening, friends. At the outset, I like to thank the IGCP again for giving me this opportunity to share some of my simple insights on a very important, it's quite common also. We see hyponatremia or low sodium level in lot of our patients day in day out, especially in critical care settings, and few of the cases incidentally detected due to some other reasons also. So as an endocrinologist, I would be highlighting today the endocrine causes of hyponatremia. So first we'll see what is hyponatremia, its definition and clinical significance, the various endocrine disorders. Commonest one, I won't be highlighting the rare or not so uncommon causes of hyponatremia. Then we'll see, in short, a simple diagnostic approach for endocrine related hyponatremia, and then very simply we'll see the management strategies. So to begin with, we'll see the hyponatremia. So what is the definition of hyponatremia or a low sodium concentration? So we say hyponatremia is defined as serum sodium concentration less than 135 milliequivalent per liter in the bloodstream. And then we classify it by severity also, like mild, moderate, and severe according to the sodium levels, which could be 130, 125, and less than 120 respectively. And then we classify hyponatremia as per the duration also. Is it acute or chronic, which definitely affects our treatment approach, because if something has happened acutely, we have to treat it immediately. But if the process of hyponatremia is slowly and progressive, we may go for a slower treatment. And then we can classify hyponatremia according to the volume status of the person also. Again, according to the volume status, we can say it as a hypovolemic hyponatremia or a euvolemic hyponatremia and hypervolemic hyponatremia, again which helps us to guide the management. So overall, we now know that what is hyponatremia. Then according to the severity, the duration, and the volume status of the patient, we can classify it, we can search for the cause, and then treat it appropriately as per its severity, duration, and status. So this is a very simplified pathophysiology and the key mechanisms which are involved in the hyponatremia. These are water and sodium imbalance. So very simply, hyponatremia occurs when water and sodium levels are not balanced in our body properly, disrupting their normal function. And as I have already told earlier, according to the volume status, we may have sometimes euvolumic hyponatremia or maybe a hypervolumic. Here, what main problem we may have is the impaired water excretion. So whenever there is a impaired water kidney function, which reduces the water excretion, it contributes to dilution of sodium in the blood. So if there is a hypervolumic state in the body due to reduced kidney function or maybe due to um, cardiac failure also, there may be water retention in the body, which leads to dilution of sodium. So whenever the water content increases in the body and the sodium level remains same, the sodium gets diluted and we may get hyponatremia or low sodium levels due to increase in the water content of body. And reasons may be, as I told, kidney, heart failure and other causes also we'll see in coming slides. And then again, one of the very important cause of hyponatremia as per an endocrinologist is the role of antidiuretic hormone. So because the antidiuretic hormone regulates water retention by kidneys and it has a influence in the development of hyponatremia. So again, coming to the clinical symptoms of the hyponatremia, it can be sometime totally asymptomatic. If it is slowly progressive or if it is chronic, yes, we may get lot of symptoms and signs in acute hyponatremia. The symptoms may vary from mild headaches and nausea to even severe neurological issues like seizure or even coma in few patients. And then when we talk about the diagnostic threshold, the diagnosis of the symptom and the patient's condition depends again on the sodium concentration. As I said, mild, moderate, and severe hyponatremia, and how quickly the symptoms have developed. So, this is again the duration of the hepatitis. So, again, it is not just low sodium levels, it is the clinical symptomatology, the condition of the patient, and how quickly the symptoms have developed along with the sodium levels. Now, coming to the causes. First, as I said, very important, the SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. Here, when we have an excessive ADH release, the SIADH, it involves the excessive secretion of antidiuretic hormone, disrupting normal fluid balance in the body. So, as the name suggests, there is a antidiuretic hormone. So, there is a water retention in the body. And as I said earlier, in kidney dysfunction, in heart failure, and other water retaining problems in the body can lead to dilutional hyponatremia. So there is no problem with the sodium level. The sodium levels are there, they are maintained by various other ways, but there is a dilution of that same sodium level and it leads to low levels of sodium or hyponatremia. What are the common triggers of this SIADH? There are few of the endocrine causes. We'll see there are some pulmonary causes, some tumors also, and some neurological disorders which trigger the abnormal ADH release. Then, another very important endocrine cause, the adrenal insufficiency. The adrenal insufficiency, we know, leads to decreased aldosterone secretion, which is very important for sodium retention. So, when we have adrenal insufficiency leading to decreased aldosterone production, and again there is a sodium loss, less sodium retention leading to increased excretion of sodium retention. So the kidneys under less influence of aldosterone retains less of the sodium. There is more excretion of sodium. In fact, I would say simply that due to aldosterone deficiency or adrenal insufficiency, there is sodium wasting or sodium excretion through kidneys leading to hyponatremia. So, this is characterized by hypotension and elevated potassium levels. So, whenever we suspect adrenal insufficiency with hyponatremia, we'll see elevated potassium levels which are again inappropriate, and patient is having hypotension. Then we have another very common cause, hypothyroidism, which is very common, but we see hyponatremia quite rarely. But yes, when we see hyponatremia, we should definitely rule out this common cause like hypothyroidism, because hypothyroidism, we all know, leads to reduced cardiac output by causing bradycardia. Ultimately, it affects the circulation and there is a fluid retention in the body. So, when the cardiac output is reduced, definitely we know there would be peripheral increase in the fluid volume. Then another, we have low GFR also. So when hypothyroidism affects glomerular filtration, it reduces the kidney's ability to filter the blood effectively. Then there is a impaired free water clearance also. Again, these all lead to the hyponatremia due to hypothyroidism. And we have seen also in a lot of patients that there is a kind of increase in weight due to increased water retention in patients with hypothyroidism. And as we start the treatment, there is a weight loss up to 2 to 3 kgs in patients with hypothyroidism, because there is a loss of free fluid when we treat hypothyroidism. So these were some of the important and main causes of hyponatremia in our general practice. Now we'll see briefly the diagnostic approach, especially when we talk about the endocrine cases. So what we should do initially, we should do serum sodium levels, potassium levels, and urinary excretion of the sodium also. Because as I said earlier, when we have low sodium, high potassium, and increased urinary excretion of sodium, we can have it in SIADH, or sorry, the adrenal insufficiency and some other renal causes also. Then we can go for osmolality measurements also to assess the concentration of solutes in body fluids, especially to see the hydration status, because as I mentioned earlier, we have to classify it as a hypovolemic, euvolemic, or hypervolemic hyponatremia also. And then again, important, I have to at least differentiate between endocrine and non-endocrine causes. So as I mentioned, endocrine causes, common endocrine causes are SIADH, adrenal insufficiency, hypothyroidism. And then we have to take into consideration other organ functions also. As I said, the kidney function, even the hyperlipidemia can also present something like this. Then the cardiac failure also, we may get problems like this, renal failure also. So we should differentiate it from endocrine and non-endocrine causes, and some lab tests can help us identify endocrine versus non-endocrine causes. So what we can do in the endocrine cause, we can go for hormonal assay, cortisol measurement. Yes, we can go for early morning cortisol levels, which can at least help us to rule out adrenal insufficiency. Obviously, hypothyroidism, so we should get a TSH at least, or sometimes a whole thyroid profile can be required. And then we may get a ADH level testing also, which can help us identify the problem with inappropriate ADH secretion. Coming to the management strategies, again, these are some of the general principles. We all know for any acute patient, we have to give a concentrated sodium through IV infusion. The 3% sodium we can give, but it should be gradual. It should be corrected gradually so as to prevent osmotic demyelination syndrome and other associated electrolyte imbalances. So first we have to see this treatment is important, but then the correction of sodium should be very slow, especially in elderly individuals and people who have a chronic hyponatremia, because chronic hyponatremia body has already adjusted itself, but the patients are lethargic, they are confused, so they need treatment, they need correction, but the correction should be gradual or slow, especially in elderlies and people with chronic hyponatremia. Yes, we may have to go a bit faster in patients who have who are in coma, who have acute hyponatremia, there we may go for a somewhat faster correction of sodium. But I would say that in 24 hours, more than 3 to 5 milliequivalents per liter of sodium correction is quite sufficient even in an acute condition. And again, frequently keep monitoring the electrolyte levels, especially the sodium levels, at least 6 to 8 hourly. And along with this, we have to observe the patient's symptomatology also, like the patient's mentation, the confusion, the lethargy, body pain, and all, because they may also guide us how we should go for correction according to the sodium levels. And definitely, when we have patients with adrenal insufficiency, corticosteroid replacement can be started along with the hyponatremia management. Patients with hypothyroidism, definitely we can start levothyroxine treatment, although it takes time, but yes, it should be started immediately if it is diagnosed and confirmed. And in SIADH, we can start with fluid restriction if it is a hypervolumic state, or hypertonic saline, as I said, 3% can be given for it. And then we have drugs also which can be used for SIADH management, but I won't go in detail of that. So this is my last slide. To conclude, I would say that identifying endocrine disorder is crucial for diagnosis of hyponatremia. And then, as I said and I told in the management, tailoring effective treatment plans should be done as per the endocrine cause. We have good modern diagnostic approaches also, techniques also, which enhances accuracy and appropriate management of the hyponatremia. And applying a good clinical knowledge, patient symptomatology and diagnostic, we can prevent complication and improve the patient's health and recovery. Thank you.
Thank you so much, sir, for this brief presentation, sir. With all your permission, sir, can I take question one by one?
Please carry on. Yes, ma'am.
Okay. So the first question we received is, sir, how can early identification and treatment of adrenal insufficiency or hypothyroidism alter outcomes in patients presenting with recurrent or unexplained hyponatremia?
Can you repeat the? Can you please repeat the question again?
Yeah, sure, sir. Okay. So the question is, how can early identification and treatment of adrenal insufficiency or hypothyroidism alter outcomes in patients presenting with recurrent or unexplained hyponatremia?
Yes, yeah, very good and practical question. Yes, definitely. Patients who present with recurrent hyponatremia, or when you see there are continuous, you can say, progressive decline in the sodium level of, I would say, especially in elderly, it is quite common, and they may be totally asymptomatic. But if they are asymptomatic also and you see a progressive decline in sodium levels, especially I say if the level goes below 130 milliequivalent per liter, definitely we should try to look for causes, as you have mentioned, the adrenal insufficiency and hypothyroidism, because they are quite common. And then we may work up for SIADH also, because a lot of patients, it is seen that if we don't diagnose the cause, slowly the patient without any symptoms may go in coma also. So a timely management is required for these patients, even if they are asymptomatic.
Thank you so much, sir. I hope you did justice with the answer. Sir, with all your permission, sir, shall I conclude the session, sir?
Yes. Thank you, madam. Thank
Okay.
you,
So thank you
IGCP,
so
and
much,
thank you
sir,
all
for such.
listeners.
Yeah. Thank you so much, sir, for such clear and practical, insightful presentation. You have beautifully simplified a complex topic and highlighted the causes of hyponatremia that are highly relevant to everyday clinical practice. So, with this, I'm concluding this session, sir. Thank you. Good
Thank you.
evening, sir.
Thank you. Bye bye.